Hello everyone. With this meeting, I want to give the start of this webinar. All very warm welcome, although via the computer and not live. Well, this is our first meeting on MRSA surveillance, so I hope the next meeting will be live somewhere. Yes, very much welcome, of course. First, I want to explain how we come to this webinar. It all starts with a study consortium on MRSA. It was a GPI consortium with France and the UK and the Netherlands, and we wanted to study the difference between clonal success. And soon we found out that that was difficult to study because there are differences in the collections in every country. So we decided that we must go on with, in the future, a harmonized surveillance, so we have a better view on the collections and we can better compare in studies what's going on with MRSA all over the countries. So we decided to, with the MRSA working group of the ISAC, to organize this webinar meeting. And I'm very happy that so many attendees are participating now, and they are coming while I'm talking more and more and more. So this is very successful already. And also I want to introduce my colleagues of the Executive Committee from the MRSA Working Group. And that is Michael David from the USA, and you will see him later on in the program. And Harald Seifer from Germany. Valerie Baede, my PhD student, and Stefani from Italy. So we are the executive committee from the MRSA working group and organized this webinar with the study question, how can we better study MRSA rise and go all over the countries, all over the world. So as this is our first meeting, we have only 2 hours and we have many people asked from different reference laboratory to fill in the questionnaire and to answer many questions. And we will first start with different countries to show us their results. And in the end, Valerie Baede will give a summary, and then we will have discussion about surveillance of MRSA. So by this now, I want to give the floor to Michael David, who will introduce the speakers of each country.
Thank you very much, Dr. Vos. The first speaker that we have today is from Belgium, Dr. Boudewijn Catry. Sorry, I'm just starting my video. So the first speaker we have today, which is this morning for me and afternoon for many of you, and perhaps the middle of the night for others of you. So welcome, wherever you're calling in from. Our first, each country speaker will have approximately 6 minutes to present information about their national or regional reference program for surveillance for MRSA. And our first speaker will be Boudewijn Catry from Belgium, the head of the unit of healthcare infection and antimicrobial resistance in Brussels. Dr. Catry.
Thank you very much. I will share my screen if that's okay for you. Is my screen visible for you?
Yes, it is. It's clear.
Thank you very much. So we have 3 surveillance programs for MRSA in Belgium. We have a mandatory aggregated surveillance, so continuous in acute and also chronic care hospitals, coordinated by us, Cienzano. We have a voluntary EARSnet surveillance, which is called EARS Belgium, and familiar to many of you. And we have also the microbiological surveillance performed by the National Reference Lab. So strains from outbreaks also in the community and so on. So the goal and aim for the epidemiologic surveillance are to measure the occurrence, of course, of multi-resistant bacteria, to map the impact of policy decisions, and also to assist during outbreak interventions and to evaluate the hand hygiene campaigns we have in Belgium. And then the microbiological surveillance is to have a follow-up on both the phenotypical and genotypical evolutions, including the resistance genes. So the level of surveillance is predominantly at national level. We also have systems at other levels, but predominantly on national. The purpose of the surveillance is all 4 items. So international, national, clinical, and for research. The final responsibility of the MRSA surveillance is the government, and the number of samples per year is about 4,000 clinical samples and more than 30,000 positive for Staphylococcus aureus. So this is the acute care hospitals only. For the microbiological surveillance, only a sample of approximately 1,000 samples are investigated at the genome level each year. The primary system for genotyping is still spot typing, although additional typing methods like pulse field and MLST and whole genome sequence is performed upon demand and for research purposes. There is a biobank, and we have numerous variables in the sampling strategy. This is the evolution on your left. The median resistance proportion, you see we come from 25% nowadays to 15%. From 2006 onwards, the surveillance was mandatory, and you have here the 3 colors for the regions. So the northern, the southern, the central part, and the national part in green. We also try to stratify it by origin. So in blue, you have the total Staphylococcus aureus population of our samples. Then we have the MRSA proportion, so methicillin-resistant, and the proportion which is by default nosocomial because of 48 hours post-admission is present. If you have an impact of the national hand hygiene campaigns, we can have evolution seen here. So in the black line is again the MRSA incidence of nosocomial MRSA, and you have the pre and post campaign compliance for hand hygiene. So you see we started in 2005 a voluntary program, 50%, and after each campaign there's an increase in compliance, and it is followed by a decrease in nosocomial MRSA. So the future plans are the harmonization of AMR and EARS, in particular for the collection of data. This is due to legal obligations, but also to improve our system with regard to ergonomy for the hospitals. We want to have a joint reporting of epidemiological and microbiological data, and we also have new plans for the nursing homes, so the long-term care facilities. We have done this in 2005, 11, and 15. We see a decrease, and we would like to have now a 4-point prevalence survey. I would like to thank you very much for your attention.
Thank you very much, Dr. Catry, especially for keeping on time, but also for your fascinating presentation. Our next speakers will be from France, and we will have 2 people speaking from 2 different surveillance programs from France together. And I'm not sure if one will speak first and then the other, or if they will both speak together. But the 2 speakers are Dr. Aurélie Chabaud from Limoges and Francois Vandenesch from the National Reference Center for Staphylococci in Lyon. Welcome.
Thank you.
So if you can maybe start your slides.
Do you hear me? Yes?
Yes, I do hear you.
Okay, all right. So I share my slides. Partager. Toc, toc, toc. Here we go. Partager. Is it loading?
It's now, it looks like it, yep, now we can see your slides. If you can put them in presentation mode, that would make them larger.
Is it okay?
Okay.
Okay, so it will be, as you said, it's going to be a joint presentation with Aurélie, but we will not speak at the same time because I don't think it's going to be feasible. So I am responsible for the NRC for Staphylococci, and Aurélie Chabaud is one of the people in charge of the national mission called SPARES, which is in charge of the surveillance of antibiotic resistance in France. So, Aurélie, can you take the microphone? This is for you.
Thank you. In France, the MRSA surveillance is carried out in part by the national mission SPARES, the acronym for Surveillance and Prevention of Antimicrobial Resistance in Healthcare Facility. It was first implemented in 2018 by 3 coordinating centers, Nancy, Bordeaux, and Limoges, under the general management of Santé Publique France. It's based on voluntary participation of healthcare facility, called HCF in the rest of the presentation. SPARES collect all bacteria from diagnostic sample associated with an antimicrobial susceptibility test. The objective of SPARES mission is to facilitate national surveillance through a common tool. Regarding the use of data, we produce indicators at national and regional level to evaluate and monitor progress, to follow trends and figures to assess the impact of national policies. At the local level, the HCF can compare themselves to others with similar size or activity. And this data would be used internally for the communication and to give feedback to HCF and lab staff.
Okay, and probably most of you know, do you hear me?
Yes.
Yes.
Not yet.
Francois, I'm sorry, now we do not hear you.
So regarding NRC, which is separate from the SPARES system, the mission are those of all NRC. So the main difference is that all our studies are based on the spontaneous reporting and not on mandatory reporting, which make a great difference regarding precise incidence and frequency of MRSA and so on. So as all NRC, we investigate outbreaks, we prove or disprove transmission based on NGS approach, we monitor antibiotic resistance, we characterize the clone, I mean, at the genetic level using NGS and all other modern methods. And of course, we also you're also aware that this system allows us to detect emerging disease or syndrome. And in the past 10 years, we have worked a lot on the necrotizing pneumonia, which is, as you know now, a well-recognized entity. And by the way, we also organize an external quality control for every national reference laboratory at the European level who volunteer to participate. So
here you can see an overview of the MRSA surveillance at the national, regional, and local level and within the research. For the purpose, at the national level, the aim is to ensure epidemiological surveillance. We will provide data for international surveillance such as GLASS or European with a CDC. Then NRC collects and characterizes unrelated strain subsets. At the regional level, the epidemiological surveillance takes place. For these two levels, the financial responsibility will come from governments. At the local level, the HCF can monitor trends, do benchmarking, and give feedback to different clinical staff. Unlike the others, this surveillance is financed by the HCF itself. Regarding to the research, SPARES can provide databases. In 2019, for SPARES, 9,880 MRSA were isolated from 66,248 strains, or 14.9%. 991 hospitals accounting for 50% of beds and patient days in France. And for NRC in 219, 2,420 isolates were tested with 21% of MRSA.
This is you or me? I don't remember already.
It's you.
Okay. Well, as you understand, SPARES collect all type of samples of infecting isolates. Carriage are not included, and the genotyping is done by the NRC on specific subsets. And you have understood that it is not the same recruitment. And we performed NGS, PAT typing, MLST, SSMEC typing as usual, I would say. Regarding epidemiological metadata, they are collected by SPARES also. Identification, location, size in beds, patient day, I mean, all useful information regarding hospital and patient, age, sampling date, admission date, medical specialty at the date of sampling, and the complete IST. You have understood that this system is automated and will aspirate actually the data from every microbiome bacteriological laboratory, and which as you heard, 66,000 isolates were studied last year by SPARES, which is really impressive. To give you an example of what we do at the NRC, this is very classical, but we collect sufficient precise information from the laboratory or the clinician who send us isolates, so we can I mean, characterize the isolates according to the disease. For instance, suppurative infection here, we have quite a high number of MRSA with 34%. And we here show you the distribution of the clone of the PVL positive MRSA as in the left corner of the slide, and on the right you have the distribution of regarding pneumonia, where we have 15% MRSA only and 27% PVL positive, including MRSA and MSSA, and these are the distribution of the clone according to PVL in MRSA, where you see the now famous USA 300 Latin variant proportion and the USA 300 sorry, the USA 300 historical strain, which is here. And for the PVL negative MRSA, we have the distribution of clone, which is actually very similar to what we observed in any other infection isolate from France. Aurélie?
Yes, here we look at the different strengths and challenges of our missions. At the organization level, the strengths are the good involvement after the first 2 years of SPARES. And for the NRC, it's the large coverage of the French territory. Nevertheless, our challenge is to increase this coverage and to improve the collaboration between SPARES and the NRC. Our missions are financed by the government, and for the financial perspective, every 5 years, the government agency selects the center in charge of MRSA surveillance with a call for tender. At the technical level, our strengths are to online free tool that facilitate data retrieval, and for NRC, the skills in genotypic and phenotypic characterization. Our challenge is how we can improve hospital and laboratory feedback, including making it quicker.
So the future goal is in 2021 will be the first year of SPARES participation in the ECDC data collection. And at the national level, the goal is to increase, as we say, the collaboration with NRC. Basically, what we would like to do is have a molecular NRC expertise on a SPARES-defined subset. The remark, the deduplication methodology in France is based on resistance phenotype and not on period of hospitalization or on patient, and this should be improved because one patient can contribute to more than one isolate. Thank you for your attention.
Thank you.
Thank you both very much for your presentation. I just want to mention to all attendees that we will have a question and answer period after all of our speakers are finished. Our next speaker is Joanna Empel from the National Reference Center for Susceptibility Testing in the Department of Epidemiology and Clinical Microbiology of the National Medicines Institute in Warsaw, Poland. Dr. Empel, would you like to share your slide?
Hello, I am. I will try to share. Okay. Okay, so I'm a leader of a small group of staphylococcal from staphylococcal lab, and we are working in a tight cooperation with the National Reference Center for Susceptibility Testing in National Medicine Institute. So my presentation will be a little different than yours because we are mainly focused on microbiological survey. The systemic surveillance and data reporting of MRSA is carried in Poland only on passive ways without the ERS-net. And there is no systematic active MRSA surveillance, but we perform specific structure surveys in different fields. And the National Center for Susceptibility Testing asked microbiological laboratories to send MRSA isolate for confirmatory testing of linezolid, vancomycin, and daptomycin, and in this way we have also insight into the changes in resistance of MRSA isolates. The goal of our group is to define clinical and community MRSA clone from different infection, to explore dynamic changes in distribution and spread of MRSA, monitoring changes in the resistance profile, identify new or not present so far in Poland of different mechanisms of resistance, and determine risk factors for coverage of MRSA in population of risk, and to provide feedback from our study to public health community. So the first structure survey was performed in 2005, and it was all performed on strains from different infections, including blood. And this was the first survey which showed us which clones are present in Poland, and it was the start point for other analysis. And in 2011, we performed another survey on bloodstream infections, MRSA, and we could observe changes between the clonal complexes, and we observed introduction of new clones, which we haven't seen before. And we planned for this year identical survey. So in this way, we could start with surveillance, but this time we decide to postpone the survey for the next year. And we also analyze isolates from skin and tissue infections and observed in comparison with bloodstream infection that we have over 30% of community-associated clone belongs to CC59, which is spread all over Asia, and it's not, I think, such popular in Europe. And also we analyzed the presence of nasal carriage of livestock-associated MRSA and in 2 different years. And we observed significant increase in MRSA carriage in risk group, which are farmers and veterinarians in contact with pigs. So our surveillance is performed on national level only, and for international epidemiological surveillance and for national surveillance, we do not have funding from government, and we have to apply for money from the National Science Center and Ministry of Education and Science and Ministry of Health. We have in our collection different isolates from different infections, and we collected in biobank here in Rhod, and the isolates, MRSA isolates, are typing, but by SPA typing, MSCC typing, and for selected isolate we perform BFG and MLST typing, and also whole genome sequencing, but it is for just few isolates, especially with new resistance mechanisms. Epidemiological data, we have the like age, gender, and when a patient admission history on request, for example, when we investigate outbreaks, isolates. And strengths, we had good cooperation between court and microbiology laboratories from hospitals, well-organized coordination of collecting data for MRSA surveillance. This I mentioned about the EARSnet, and most probably in this year, the National Reference Center for Susceptibility Testing will be applied by the Minister of Health, and government funding for MRSA surveillance is accepted in this way. So the changes: we have no national reference laboratory for Staphylococci, and National MRSA Surveillance Program is in preparation, and no stable finding up till now. And we have no wider use of whole genome sequencing. So our plans are that every 10 years, we would like to perform the survey on MRSA isolates from bloodstream infection, and every 10 years on skin and soft tissue infections. And we like to implement WGS to the study of MRSA isolate collection. And we are willing to participate in any international surveillance program if it is possible. Thank you for your attention.
Thank you very much, Dr. Empel. Our next speaker is Dr. Andreas Kronenberg from the Institute for Infectious Diseases at the University of Bern in Switzerland. Dr. Kronenberg.
Good afternoon, everybody. 2 people will speak about Swiss data. My part is to present the more phenotypical surveillance system on RESIS. This is the aim not only to collect data on MRSA, but collect data on all microorganisms directly from the clinical routine analysis. We collect data from about 31 human medical laboratories, from 9 veterinary laboratories, and in the same system we also collect data on antibiotic consumption of around 70 hospitals and 1,000 pharmacies, all distributed over Switzerland. And the main outputs are epidemiological research. We are also connected to the GLASS and the CSAR network, because we are not belonging to the European Union. We are not participating in EARSnet, but in principle, this is the same system and the same data which are collected. One of our focus is really to not only focus on human data, but also collaborate with veterinarians and to a lesser extent with environmental data. And an important point is we also give not only feedback to the government and present the data continuously on our website, but also give individualized reports to specific hospitals to make them comparable to others via an anonymized benchmarking. Just to give you an impression of what we have about 400,000 samples nowadays, but it's not a sample. We do not have any biobank, but just get the resistance data from the individual hospitals, the phenotypic resistance data. The cornerstones of our program is the participation is facultative. We collect all routinely generated resistance data in clinical practice from all microorganisms, from all sample locations. The data are delivered automatically weekly or monthly. There's no systematic national biobanking so far. I know from several hospitals which are collecting invasive samples, but there's no collection at one single place. The data is available for public and for physicians. We give direct feedback and benchmarking reports, and molecular database is built up, and the next speaker, Domnique Blanc, will show the more detailed data on this side. One advantage of our system there is that we not only collect samples from wards, as here marked with a W, but also from specialists, from primary care physicians, and a few samples from long-term facilities. And on the right lower side, you see in green the hospitals which are participating in our surveillance system. The orange ones are missing, but you see that we are covering very well the whole Swiss area. The data are like this. Sampling location is more than half of the cases are urogenital. That's also shows that we have collected a lot of ambulatory physicians data, and about 7.5% of the sample locations are from blood. And of all microorganisms, the majority is Escherichia coli, and about 10% of all microorganisms are Staphylococcus aureus. If you go now into this Staphylococcus aureus, you can have a look at our website, www.anresis.ch, where you can see the most important microorganisms, and here in gray you see the MRSA rate declining. What we present on our website is the invasive samples only, to avoid pushing hospitals which are really have a broad screening program to have more MRSA. We restrict the publication of the data to invasive cases. On the lower side, you see the curve from 2004 to now. You see a steady decline in the MRSA rate. The number of MRSA is about stable because we increase the participation of the laboratories. With this, I will thank you all the laboratories participating and to me, my collaborators, and thank you for your attention.
Thank you very much, Dr. Kronenberg. I appreciate that. Our next speaker, also from Switzerland, as Dr. Kronenberg mentioned, is Dr. Domnique Blanc from Lausanne University Hospital in Lausanne, Switzerland. Dr. Blanc.
Yes, hello, thank you very much. Here we are. So you've heard that in Switzerland there is no mandatory center for laboratory or for staphylococci, and moreover, it is not mandatory to declare MRSA. And as you heard from Andreas Kronenberg, the surveillance of MRSA is provided mainly at the national level by the MRSA program. But in addition, there are some local initiatives, and I will try to present you one of them. So in quite long time ago, in 1997, we performed the first molecular surveillance of MRSA. And since then, most laboratories in Western Switzerland only continue to send us MRSA isolates for typing. And this allowed us to perform several studies to understand the spread of MRSA at a regional level. But nowadays, these typing results are mostly used by infection control team for the surveillance of MRSA in the institution. And let me show you just one example where this continuous surveillance was a real advantage. It was in a regional hospital in 2018 where a chain of transmission was suspected when two babies were found to carry the same DLST type. DLST is double locus sequence typing. It is molecular typing that we developed in our lab. And investigation in the maternity ward, including babies, parents, staff members, were done during the summer and revealed 8 other persons contaminated with these genotypes. So as MRSA from these hospitals was typed since many years, we were able to draw a draft incidence curve of genotype over the year. And we realized that the genotype involved in 2008, the DLST 19.2, which is in red here, was responsible for an outbreak that started in 2011 and probably with a peak in 2013. So the raised question about the 2018 cases is that are they part of a chain of direct transmission, or are they independent descendants from the 2013 outbreak? And so we perform whole genome sequencing to try to resolve this question, and we select only isolates belonging to this genotype, and several from 2013, so one from 2017, and all of them from 2018. And these three show us that direct transmission indeed occurred in some cases, such as in babies and parents, or even staff members here, but the diversity for us was relatively high, suggesting an underground reservoir outside the hospital. Unfortunately, there was no resources to continue this investigation outside the hospital. So the real strength of the surveillance of antibiotic resistance in Switzerland is definitely MRSA. And the challenge is the investigation of outbreak involving more than one institution or outside an hospital. In this case, the public health officer of the canton is in charge and have limited resources. And if the outbreak is intercantonal, all public health officers must cooperate. And it is only for a national or international outbreak that the federal state can start to interfere in the investigation. And this happens only once, for the first time, with the COVID-19 pandemics. So thank you very much for your attention. Oh no, future PN, yeah, the last slide, sorry. There is a need indeed to compare pathogen at a national level. And there is a project, an ongoing project, the Swiss Pathogen Surveillance Platform, which might meet this need. The concept of this ongoing project is to have a web-based tool allowing us to analyze whole genome sequencing data together with epidemiological data. And this project was supported by the Swiss Foundation for Research, and the project leader is Andreas from the University of Basel. So thank you very much.
Thank you very much, Dr. Blanc. Our next speaker will be Dr. Anders Rhod Larsen, the head of the National Reference Laboratory of the Statens Serum Institute in Copenhagen, Denmark. Dr. Larsen.
Thank you very much. I will just share my screen. You should be able to see it now.
Yes, we can see it. If you can put it in perfect, that's perfect, thank you.
Okay, well, I'm going to present the Danish MRSA surveillance system. And it was fully in place by November 2006, although that it actually started early on. But in 2006, submission of isolates and also reporting of epidemiological data became mandatory, and that isolates and the epidemiological data was submitted to Statens Serum Institute as a national reference center. And the goal was to assist in outbreak situations and to have a national epidemiological surveillance system. We say that the surveillance is research-based, and I will come back to that, but it's expected to support infection control locally and increase our preparedness nationally, and also to provide data for international surveillance of the epidemiology of MRSA. Some of the research that are based on these data that we are gathering are expected to increase our translational and basic research, and with a specific aim at looking at bug and host interactions. Well, I've just been giving the purpose of the surveillance. There is also surveillance going on regionally, with some of the same aims as nationally, but just on a regional basis, and they are often also connected to the local clinical departments and to perform outbreak analysis. All our activities are paid by public money, governmental or regional, but I've just stated here that they are governmental, even though that at the local level, it's of course affecting the hospital's budgets. And for our research, we both have some internal funding, which are founded in our surveillance system, but are also dependent on external funding for further projects. I haven't put on any nice features, so I would just say that we have seen a rapid increase in the number of cases since the beginning of this surveillance, but it has stabilized since 2016, where we are having around 3,600 isolates per year, and that has decreased a bit in last year due to the COVID-19 situation. So what do we get? We get actually all MRSAs that are diagnosed. So it's all isolates from both infections and carriage isolates. We have a standard genotyping system where all isolates are run through a multiplex PCR, and that will detect both the SPAR gene, MAGA, PVL, SCN, and a CC398 specific HSD gene. And the last gene is quite important, as we see that approximately 1/3 of our MRSAs are livestock associated and mostly of the CC398 lineage. So by that we can determine the livestock associated MRSAs, which we will not type any further or characterize any further in our normal surveillance. The rest of the MRSAs are subjected to SPAR typing, and that's approximately 2,500 isolates per year. And among those, we see quite or many that are only sporadic SPAR types that we see very few of, and the remainings that are belonging to the larger clones, they're subjected to whole genome sequencing, and also we do that on demand in case of any outbreak situations. And from the whole genome sequencing, we determine both MLST and SSMEC. We do have some biobanking at SSI. We have stored all MRSAs since 1999. And in addition, also bacteremia cases, MSSA and MRSAs since 1957. We receive all many kinds of metadata, and much of that is based on that all citizens have a social security number, from where it's also possible to combine registers of interest. But we do, from the reporting system, get age, gender, sampling day, place of residence, or that would be the postal code, and also there would be some individual risk factors like contact to livestock or recent travel. So I think I can say that our strengths are, well, one I maybe missed is that our main strength is that we are a low prevalence country, so we can really get every isolate. And that means also that we're able to follow trends in the community more easily than in many other countries. Then we have very well integrated both laboratory and epidemiological departments sitting next to each other at SSI. And we have digitalized many of our registers where we use this social security number as a common key. And then we have a VGS pipeline that makes 2 to 3 runs weekly, which means that we can also use VGS for outbreak analysis. Some of the challenges that we are facing now is sharing of data, mainly whole genome sequencing data. More and more hospital laboratories are using whole genome sequencing, and we need to have a system to share these data. I also mentioned GDPR rules because it has become more challenging to communicate patient data between hospitals and the National Reference Center. Some of our future plans are working with these whole genome sequencing sharings. We're working on a platform where we can share both bioinformatic tools and also data between the reference center and the regional laboratories. And then I hope that we will VGS implemented in more and more countries, that we can have a more real-time sharing of surveillance data also between countries, so we can have a faster communication and thereby also faster responses to emerging clones. And I also imagine that we could include EQAs on different bioinformatic tools to some of the present phenotypic and genotypic EQAs that are running. So with that, I will end and say thank you very much.
Thank you very much, Dr. Larsen. We appreciate your attendance today and your presentation. Our next presenter is Dr. Leo Schouls, who is a molecular microbiologist at the Infectious Diseases Research, Diagnostics, and Laboratory Surveillance at the Center for Infectious Diseases Control of the Netherlands in the National Institute for Public Health and the Environment. Dr. Schouls.
Good afternoon. Thank you for the introduction. I will share my presentation now. The Netherlands is a low incidence country as far as MRSA is concerned. So in general, we do not have a lot of antibiotic resistance, but we do have, I think, a nice national system for MRSA surveillance. I want to move on to next. Okay, so the goal and the aim. Our primary goal is to monitor trends in prevalence and changes in strain properties and modes of transmission, and it has to support policymakers on taking measures of intervention. Secondary goal that we have is to support infection prevention departments in Dutch healthcare centers by reporting or typing within 48 hours, and this will help to prevent transmission within and also between healthcare centers. The work we do in our institute is a joint effort of the Department of Epidemiology and Microbiology. And we have a system where all 55 medical microbiology laboratories in the country submit their isolates to our institute for characterization. So the rest of my talk will be on the characterization that we do in our lab. Oh. Okay, I'll give some examples of what we do. This is an example of the incidence or the prevalence, I should say, of MRSA. So in the first bar graph, you see the increase that we had over the last couple of years of the number of MRSA isolates that have been submitted, and for which we could assign a genomic group. You can see in the middle panel that the number of 398 isolates is dropping. But if you look at the right panel, you see that the number of CC6 or GG6 isolates is increasing quite dramatically from nothing, virtually nothing in 2008, 2010 to about 3.5% in recent years. The other thing that we do is some sequencing, whole genome, MLST typing. And these are two examples of the type of investigations that we do. This is a tree of livestock-associated MRSA. And you can see the distribution in the left figure of a aminoglycoside resistance gene. And in the right figure, in the right tree, you can see the presence of PVL. We see quite a dramatic increase of PVL in livestock-associated MRSA. We now, up to 9% of our isolates are now PVL positive. This is what we do. We have a national surveillance. We also have national epidemiological surveillance. It's paid by the government, and we collect about, or we receive about 4,500 samples annually to do characterization on. So we get isolates from clinical and screening specimens. So that is mostly swabs from nose and throat. We perform MLVA, that's our standard typing method, although we also do whole genome sequencing on a subset of isolates. The isolates that have been submitted, all isolates are being stored in our freezers. We currently have 53,000 isolates stored, that is from the time period 2008 until now. We have a system where the laboratories also supply metadata via a digital system. It's called TypeNet, and we get data on the isolate, for instance, the sampling date, on the patient, for instance, the 4-digit postal code, and then we have questionnaires that can be filled out, and about 80% of the isolates that we do get actually have a questionnaire filled out, and that is information on whether this is a patient or an employee, whether this person is admitted to the hospital, if there's underlying disease, and other things like contact with livestock. And this is what it looks like in our TypeNet system. This is in Dutch, so I don't expect you can read it, but I think you can see that we have specimen data, which is the top part. We have patients data, we have typing data, and we have the data on the questionnaire. This is actually visible for the people who actually use this TypeNet system. Like I said, we have TypeNet, and this is a paperless system. It's a digitized system for submitting isolates and metadata. It's in the central facility in our lab, so the reference lab. We perform MLVA and NGS. And the MMLs, the laboratories that submit the isolates to our institute, can actually query the database. And this is an example of the sort of results you can get. You can do a query in TypeNet and then look at a particular, in this case, MLVA type in 2 different time periods. And you can see the spread of this particular type over time. This can also be done animated. The MLVA typing is free for the labs, the medical microbiology labs, and that's also the case for NGS. And actually, we report back the NGS data. That is, the labs can download the raw reads from the NGS that we perform. We do not have sufficient funding to perform NGS on all isolates, and this is one of our problems. I think we have a lot of expertise on EPI and molecular analysis in our lab, in our institute. What kind of future plans do we have? Well, we want to report the data that we do have on NGS analysis, like genetic clusters based on whole genome MST and the presence of acquired resistant genes, virulence genes, etc., in the TypeNet system. And this is an example what it looks like already in our system for TypeNet for carbapenemase resistant Enterobacterales. And in the top part, you see some general typing stuff. And then in the lower part, you see the stuff that comes out from the NGS analysis. For instance, a cluster, a genetic cluster where the isolate belongs to, and also the resistance genes. Thank you.
Thank you very much, Dr. Schouls. Our next speaker is Dr. Guido Werner, who is a medical microbiologist in the Department of Infectious Diseases at the Robert Koch Institute from Germany. Dr. Werner.
Yes, so good afternoon, everybody. So this is the presentation from Germany. I'm representing the Robert Koch Institute as the Central Public Health Institute in Germany. And as you can see on the next slides, where most of the surveillance data are collected. So the three main pillars for the MRSA surveillance in the country is first a nationwide mandatory MRSA notification of cases from bloodstream infections. This is the run to assessing incidence trends and is in place since 2012. We have as the second pillar a voluntary resistance surveillance of Staphylococcus aureus isolates from ambulatory and stationary care. This is in place since several years with a substantial coverage of about 50% of the German population. And as a third pillar, we have a voluntary MRSA strain characterization at the National Center for Staphylococci. So all of these data are collected at the Robert Koch Institute, as I said before. So we have the different levels of surveillance, and I was asked to fill this table out. So I'm coming back to all those three pillars. First is MRSA surveillance from bloodstream infections. Second is Staph aureus surveillance of resistance data. And third is the data from the National Reference Center. So all of these trade data collections allow national assessments. And from the first two reports are sent to the European CDC for the EASNet reports and to WHO GLASS for the resistance surveillance reports of WHO. Also, data from all the three surveillance schemes allow regional assessments, and the national and regional assessments are mostly the government, for instance, as the work is paid for the reference center. Since Germany has a federal system, also regional, meaning federal level, there are also additional tools for multi-drug resistant bacteria surveillance, including MRSA, and this is then partly financed by the federal governments. Each hospital is required to collect and evaluate its own data on multi-drug resistant bacteria, including MRSA. So this is there the hospitals are in charge. So the first pillar, the MRSA notification from bloodstream infections, this is from 1,000 to 3,500 cases per year, really decreasing trend in the last years. The second system collects data of more than 100,000, in this case, Staph aureus isolates, including MRSA. And we at the Reference Center characterize and type about 2,500 to 3,500 mostly MRSA per year. So what we do as a standard genotyping method is still SPA typing, as also other presenters told. Of course, we use also next generation sequencing, but for selected questions in terms of outbreak or scientific questions. I would like to mention that the first and the second pillar, this is mainly surveillance. So we do not have any strain collections associated with it, with the MRSA from bloodstream infections. And the collection of the National Reference Center, which is since 1995, it's more than 80,000 staph isolates, mainly MRSA. So it's not a clear biobank, it's a strain collection at our National Reference Center. So almost all the samples are stored at -80 degrees as glycerol stocks. There are some metadata coming along with the data collections, MRSA from bloodstream infections. We have some metadata on age, gender, the sampling date, and the place of residence with the postal code. And for our strains analyzed at the National Reference Center, we have some metadata requested for age, gender, sampling date, partly a place of the laboratory sending the samples in, but not a place of residence. There are some strengths and challenges. The first point, I mean, the federal and national structures could be a strength or a challenge. So I put it here in both lists. So we have the strength that all the data are at the Robert Koch Institute as the Central Public Health Institute, also in different departments. We have for most of those surveillance schemes a good coverage, meaning the national and the regional level. We have a mandatory MRSA notification system in place since almost 10 years. All of the data, and I've not included any data yet, but we see decreasing MRSA trends according to different schemes and actions. At least in Germany, we can claim that the situation with livestock MRSA and community MRSA is more or less under control. We do not see any dynamics in this field. And as a further benefit, we have a strong Staph aureus research community in Germany. So challenges could also be federal structures in this case, since, for instance, establishment of genome-based MRSA surveillance is partly done at the federal level, not necessarily at the national level. As I introduced, we have 3 independent systems for MRSA surveillance, and the aim would be to combine some data in some systems. Only the third one, the voluntary collection at the National Reference Center, has access to IS, not the first 2. We as a National Reference Center have access to NGS, but we are not doing NGS-based surveillance for all the MRSA collected. And of course, there are always financial, personal, and technical limits. So our future plans are at least to bring some of these systems together, the mandatory MRSA surveillance for blood cultures and strain characterization at the National Reference Center. We plan a transition from SPA typing to genome-based MRSA surveillance, of course, coming along with a much better resolution. We will try keeping livestock MRSA and community MRSA under control, also in areas with high livestock densities in the northern parts of Germany. We watch out for last resort resistances, which is daptomycin resistance or linezolid resistance in multi-drug resistant Staph epidermidis, as we see it in Germany. And we are in full support of establishing the international nomenclature of strain types, which is also an issue for the ESCMID study group on staphylococci and staphylococcal infections, and which is, according to our idea, really important if we more and more use genome-based MRSA surveillance. Okay, thank you for your attention.
Thank you very much, Dr. Werner. Our final speaker is Dr. Helena Žemličková, who is the head of the National Reference Laboratory for Antibiotics at the National Institute of Public Health in Prague, Czech Republic. Dr. Žemličková.
Hello to all of you. Thank you for the introduction. So I will try to share the screen. So, okay, could you see my slides?
Yes.
Yeah, thank you. So once again, I'm head of National Reference Laboratory for Antibiotics. So not just MRSA, but antibiotics. We are working with the surveillance for all antibiotic-resistant, mainly human pathogens. And we are located at the National Institute of Public Health in Prague. Regarding goal and aims of surveillance of MRSA, we are responsible for national surveillance of MRSA strains, and we are mainly focused on the surveillance of invasive MRSA because we are participating in EARSnet surveillance. So from 2001, we are participating in EARSnet, and we are performing the national and also, I would say, supranational data on MRSA prevalence in the Czech Republic, at least for invasive infections. We are performing also molecular surveillance of MRSA. We have started 10 years ago with molecular surveillance that was related to the point prevalence studies and prevalence studies organized by used leader of EARS by Heil Grundmann, spot typing of MRSA isolated from bloodstream infections. And we are regularly performing spot typing of all invasive MRSA strains and also MLST or SSC-MEC typing of selected isolates, I would say. We are also checking for occurrence of vancomycin not resistant, because we have not observed vancomycin resistant Staphylococcus aureus strain in the Czech Republic, but for intermediary resistant strains, which are very rare. And as a national reference laboratory, we also serve as a reference laboratory for confirmation of MRSA, and we are performing also confirmation of MEC-C MRSA for local laboratories, or confirmation, let's say, of all MRSA strains which have been sent from the local laboratories. So the level of surveillance is a national, and also purpose of the surveillance is a national surveillance, and also we are, as I said, part of international epidemiological surveillance. We are submitting data to EARSnet, to ECDC, and also via ECDC to GLASS network. We have governmental funding for national surveillance. And for some projects, because we have some also research projects which are based on MRSA surveillance, they are funded by, of course, by research agencies. We have around 250 MRSA isolates per year. Sometimes it's a higher number, I would say. Regarding the genotyping, as I said, we regularly perform spot typing. On selected isolates, we are performing also MLST typing and SSC-MEC typing in cooperation with National Reference Laboratory for Staphylococci. We are also checking for the presence of some toxin genes like PVL or enterotoxin and other genes. We are not regularly performing whole genome sequencing, but for some research projects, we are also able to perform whole genome sequencing. It was outsourced, but we will be able to do it within our institute. Regarding the biobank, yes, we do. In the reference laboratory, we store all MRSA isolates which have been identified from 2001. So we have a collection of MRSA for 20 years, I would say. It's a very big collection. Regarding the metadata, we are asking for the basic metadata set, age, gender, sampling date, source, because we are not collecting only invasive strains, but also the MRSA from all sources. We are asking for the patient admissions, so we are checking if the strains are community acquired. Usually by communicating with the laboratories or hospitals. We are asking also for the sampling date and sometimes for the diagnosis of the also of the patient. This is just the very short example of our data regarding the MRSA situation from the bloodstream infections. For more than 20 years, we have very stable situation, around 15% of MRSA from bloodstream infections. You could see that almost 20 years ago, we have observed the change in the prevalence of the certain clones, which was most probably related to the higher prevalence of MRSA. And those clones are very stable. Right now, you could see from the SPA typing from the last year, we have the presence for 80% of the strains they are belonging to the three main closely related SPA types and to the one major clone, which is highly prevalent in the Czech Republic. So regarding the strengths and the challenges, I would say that we have a very good network of local laboratories. We have more than 50 laboratories which we are cooperating with them on the really daily basis. We have a long-term cooperation with them, and those laboratories, they serve for up to 85% of the Czech population. So I would say that we have very good national coverage. On contrary, we don't have any mandatory rules for MRSA surveillance, even for the antibiotic resistance rate, for any surveillance regarding the antibiotic resistance. But I have to say that on voluntary basis, we have much better cooperation with our laboratories, and I'm not. I don't believe that mandatory rules would enhance our surveillance, because we know that unfortunately in the Czech Republic we are used to many rules, mandatory rules, but we are not so good in complying with the mandatory rules. So I would say that voluntarily based cooperation, it's much better. And also I would say that we would have, because 20 years ago, we have started, or at least another part of our hygiene system has started the surveillance, the regular mandatory surveillance for MRSA. And it was just a mess, because we don't have any clear rules how to rules for sampling, I would say, for MRSA. So we don't have a data which we could compare between the hospitals, because the rules for the hospitals were different. Regarding the financial strengths and challenges, I would say it's the same for every country. We have financial support for our laboratory, but we don't have any financial support for the shipment of the isolates. For the local laboratories, we have only limited resources for data management and for software support, because we don't have a special software and link with for the data shipment from the local laboratories, but the resources are very limited. Regarding the future plans, we would like sustain the molecular surveillance, which is not so easy. Regarding the founding and regarding also the personal capacity of our lab, we would like to maybe start also with whole genome sequencing, at least for some projects. Regarding the community-acquired MRSA and LA MRSA, we rely only on some prevalence studies which have been performed in cooperation with some veterinarians laboratories for LA MRSA or with some other laboratories for community-acquired MRSA, but I have to admit that we don't have any regular surveillance for prevalence data on occurrence of community-acquired MRSA or LA MRSA in the Czech Republic, but at least for LA MRSA, we have data from veterinary studies. We would like to also take part on the linesolid resistance, on the surveillance for linesolid resistance in Staphylococcus aureus, which is very rare, but we have started to follow the situation in enterococci, and we will use those the know-how also for the linesolid resistance in Staphylococcus aureus. And as I said, mandatory MRSA surveillance, we are always discussing if it should be mandatory or not, and we'll see what will be the solution for the mandatory MRSA surveillance. Thank you for your attention.
Thank you very much, Dr. Žemličková. We have on the schedule a period for questions for the individual speakers, but I think we will defer those questions until the discussion period after the next presentation in the interest of time. Our next presentation will be by Valerie Baede, who is a graduate student in the Department of Medical Microbiology and Infectious Diseases at the Erasmus University of Rotterdam, and she will be speaking on the results of our questionnaire that we have had filled out by our country panelists today and others who didn't present today. And she will present the aggregated results of MRSA surveillance laboratory data that we have accumulated. Valerie?
Yes, thank you, Michael, for your introduction. I will share my screen. Yes. So yeah, thank you for your introduction. And today I'd like to present to you the results that we have so far of our survey on regional and national MRSA surveillance programs worldwide. First, I want to look with you to the background into this survey. And in infection control and MRSA research, sometimes we encounter difficulties comparing national strategies dealing with MRSA. Often one of the problems is the variation in surveillance strategies, and this leads to differences in the available data on MRSA cases and isolates. I'm a researcher in the MACOTRA Consortium, and the MACOTRA Consortium is a European research consortium which looks at the success of MRSA, certain MRSA clones. And within our consortium, we experienced difficulties coming up with the standardized definition for transmission success of MRSA, as the data that was available to us varied widely between the countries. And therefore, together with the ISAC MRSA working group, we aim to capture the diversity of the national and institutional MRSA surveillance programs through our survey. And I have to emphasize that this is not on the analysis of the data collected in these programs, but merely on the type of data and the diversity of the data collected in these programs. And hopefully with the presentations that have already been given by the other country representatives and my summary now and the discussion later on, we can move towards a harmonized approach for surveillance programs, ensuring high quality data for public health as well as MRSA research. So for our methods, we identified a national and regional staphylococcal reference laboratories and their representatives with the help of our ISAC MRSA working group members. And additionally, we included the national institutes and organizations that participate in EARSnet. As you have already, it has already been mentioned, but EARSnet is the European network for antimicrobial surveillance in Europe, which is organized by the European Center for Disease Prevention and Control. So the laboratory representatives that we identified were included or invited to participate in our survey. And this survey included the following topics: the surveillance structure in a country, the goal of the surveillance, data that is available on samples and strains, the epidemiological metadata that was gathered, and also laboratory reports that were maybe sent back to the referring laboratories. So we were able to invite 32 lab representatives, and we got so far 16 responses. So I will only be able to give you the data for these 16 responses that we have so far. And these included 15 countries that you see on this map here in gray. And as you can see, our results so far are very European based. So I'd like to take the opportunity to invite any lab representatives of other parts of the world to participate in our survey. So if you're interested, please send me an email or to any of the other webinar organizers. And then for the results. Overall, we can say that the surveillance is standardized in 13 countries. And if this is not on a national level, it is usually on the hospital level, covering 80 to 100% of the population. As you've heard from the country representatives before, sometimes there's not one surveillance program available in a country, but it is, for example, separated on epidemiological and microbiological surveillance. Overall, if there is funding for these programs, it's usually funded by the government or a hospital trust. So we compared our surveillance results to the data available through EARSnet to discover how much more data is collected in the surveillance programs than is already available on an international level. So as I said before, EARSnet is the European surveillance network, and in EARSnet, invasive isolates are included from bloodstream infections and cerebrospinal fluids. Then this data is very nicely depicted in the Surveillance Atlas of Infectious Diseases, which you can look up online. And for example, here you can see the percentage of methicillin-resistant isolates of Staphylococcus aureus in the participating countries in 2019. Also in our survey, we asked about the numbers of isolates that were collected. And it's very important to note that most of the programs that were already presented to you and that are included in our survey do not only look at bloodstream infections, but for example, also at long-term care, primary care, sometimes even the general community. So we were wondering, how does the number of isolates in EARSnet extrapolate to the total number of MRSA? And for this, we calculated the BSI to total MRSA ratio, because as we know, bloodstream infections have a very clear definition. So the numbers that we have on these infections are of very high quality. For this, we asked the laboratory representatives of Norway, Denmark, and the Netherlands to provide us with the number of isolates that were collected in 2019 through their national surveillance. And why these countries? These countries have a very similar surveillance program where either MRSA is a notifiable disease or it's very much encouraged to submit any isolate from any kind of care system or even from the general community. So from these countries, we know that we will get a nice estimation of the MRSA incidence in their country. So here we were able to calculate the BSI to total MRSA ratio in these countries for 2019. And if you look on average, if we average these numbers, then we can say that 1% of the total MRSA will originate from a bloodstream infection. If we then assume that this ratio is the same in all countries, we can extrapolate from the EARSnet data how many isolates we would expect in each of these countries for MRSA, which you see in this column, and then compare to the isolates that are recovered by the survey in this column. Of course, some countries may have several surveillance programs, so we may have to include other numbers, but overall you can see that the surveillance structure in these countries leads to an underrepresentation of the MRSA that are not included in the bloodstream infections. So there's an underrepresentation of MRSA in these surveillance programs. And of course, there are a few very obvious reasons for this. For example, population size or prevalence of a country or the laboratory capacity. And it might not be feasible for all of these countries to adopt the same surveillance strategy as is now present in these Nordic countries. But let's look at some similarities. So we included now, or we have had responses from 16 surveillance programs so far. And overall, we can say that most of these surveillance programs also include community cases and primary care cases. Most of them, or actually all of them, include infection isolates, and also 11 of the programs include carriage isolates. Then, as expected, all of them include blood isolates, and a lower number do include skin isolates or nose, throat, and perineum isolates. Which makes us wonder if this was active or passive surveillance, but we can discuss about that later. Many programs do collect all invasive isolates or any isolates, including the carriage. So I think it's very interesting to note. And then if we look at the purpose of surveillance, you see that most programs work on the clinical questions. So that's their main purpose of surveillance. So most often it's also national surveillance, and otherwise ECDC data collection or research can be another reason to do surveillance. And I think you can see that the primary goal of surveillance leads to the different surveillance structures in these countries. So if, for example, an AMR reference laboratory is the main center included in the surveillance program, you will see that there's an emphasis on epidemiological data. Well, if it's organized by a staphylococcal reference center, you will see that there's an emphasis either on clinical questions or maybe even on virulence factors. Then some information on the data of strains. We asked about the default testing that was done in the different surveillance programs. And you can see that in these three columns. So quite a lot of the programs did some kind of antimicrobial susceptibility testing. If this was done, it was usually done through the UCAS guidelines. And if they didn't do it, usually the information about antimicrobial susceptibility was already available through the referring laboratory. Quite a lot of programs also looked at virulence genes. And if they did, usually it was the PVL gene that was the most important one that we found. And 9 surveillance programs also did genotyping. And in the European countries, we could see that SPA was the most used standard genotyping technique for the USA, which was the only country outside of Europe that participated in our survey so far. Whole genome sequencing was actually very important. Other typing techniques in Europe, for example, also whole genome sequencing or other typing methods were used either for outbreak investigations, specific research questions, or for monitoring livestock associated MRSA. When you look at the epidemiological metadata that was available in the different programs, you see that there's, of course, an emphasis on the who, where, and when. So the age and gender of the patients, the sample date, and the place of residence. And there was much less information available about risk factors or maybe even outbreak information. And then to conclude, I think we can all appreciate that there's a lot of money, time, and effort put into the MRSA surveillance, at least in the countries that we have included so far, but yeah, for most of these programs. Often infection and carriage isolates are included, hospital and community isolates. So there's a lot of data available together if we put all these programs together. But I think the challenges are that there is different structures of surveillance done at different levels, either at the national or at the hospital level, and that the primary goal drives the structure of surveillance. And this will lead to a selection bias of the MRSA isolates that are gathered. And this makes it harder to study risk factors, MRSA trends, or success factors. As on an international level, we have no reliable comparable data. So I think it's a shame if we wouldn't use the data that's already present in these programs. So I'd like to invite you to discuss how we can harmonize these surveillance programs. And I'd like to thank you for your attention.
Thank you very much, Valerie, for that presentation. I also very much appreciate that you sped up your presentation to save some time and still get through all of the material you wanted to present. So thank you very much. I think that was a very nice summary of the questionnaires that we received. So now I'd like to open up the time for discussion on any of the presentations that we heard from the individual country presenters, or for Valerie, or more generally, if people have questions about national surveillance programs and how we might be able to harmonize them. This discussion portion will be moderated by me and also by Dr. Harald Seifer. If there are any questions, you can raise your hand by clicking the raise hand button at the bottom of the screen, or you can use the Q&A function also at the bottom of the screen and type in your questions. I have one question that's come through to me by direct message from Dr. Werner from Germany. Maybe we can start with that question. And then I just like to say we welcome questions from the panelists as well. So please feel free to join in. So the question is there an issue in the various countries with very antimicrobial resistant Staph aureus? For example, is there an issue in your country with linezolid resistance in Staph aureus or MRSA, linezolid resistance in MRSE, or daptomycin resistance in Staph aureus or MRSA? And how do you monitor these resistant strains? So we'd welcome any responses from the panelists.
Can I respond to that? For the Netherlands?
Please do.
We are collecting resistance data from all the laboratories in the Netherlands, and linezolid resistance is low. However, we checked our NGS data as well, and we found the CFR gene in 5 of our isolates. So CFR is actually also causing resistance to linezolid, but also against other classes of antibiotics. Actually 5 different classes at once. And all of these isolates were livestock-associated MRSA isolates. And this is not a spread of a particular strain, because it turned out that in the whole genome MLST analysis we did, these were totally different, genetically different isolates. So I think there's a couple of mechanisms that may be responsible for linezolid resistance. It's the mutations of the 23S RNA gene, but it could also be methylation by the CFR gene, which is has more impact, I think, than the mutations. And also, the CFR gene is located on the mobile element and plasmid. So the situation in the Netherlands that we found some of these CFR-containing isolates, and we only found it because we had NGS data, and we do not know what the level of problem is in the Netherlands, but it's still quite low.
Do any of the other panelists, representatives have a comment on this? Dr. Larsen?
Yes, I just want to support Leo Schouls in his observation, because we have seen the same in livestock-associated MRSA in Denmark, and it could be linked to the usage of pleuromucilins in the animal sector. That's a possibility. So it seems to be quite widespread in the isolates that we've looked at.
I see we have a question from Dr. Yusuf in the Q&A discussion. And the question is MRSA surveillance in the environment not a priority in Europe? In Africa, specifically in Nigeria, we persistently isolate MRSA from restroom floors of our college, although we only use a phenotypic method to confirm MRSA. So that raises the question, is there any surveillance in your country for environmental contamination with MRSA?
Well, I can answer this question. We used to do that many years ago, but we stopped that after we found the reliable methods to clean and disinfect the patient room after discharge. So we are not doing that. So it's like more or less an end control of infection prevention policy, and we better monitor the cleaning staff members. But this is more about the infection control. So I want to take the opportunity to come back to our main question, and it's about doing surveillance in many countries. We have seen that the overall aim of many labs is collecting for bloodstream infections. So thanks to EARSnet, so this is our common and shared goal and aim. But then it comes to the question when we want to do research together or to have an understanding of rising and go of clonal clusters. And as MRSA travels with us as persons, and we travel over boundaries, it's an international problem. So how can we come together more and not just on bloodstream infections or bloodstream data or not even strains? So how can we come together that we have a common and shared, so by harmonization of surveillance methods, that we can more study internationally the rise and go in the MRSA or the rise and go of resistant genes, variant genes, etc. So that's my main question to the audience. How can we perform better in near future? Do anyone have ideas about that?
Can I
Yes, Dr. Vandenesch.
Yeah. Following what Margreet said, I think there is if we want to anticipate and control the evolution of MRSA, I think we all agree that we need some genomic characterization of those isolates, and to do so, as pointed by Valerie, in most countries, the epidemiological and the microbiological surveillance are separated, and so I think the main issue, and that was one of our conclusion in our presentation, but also that of Guido Werner. I think the challenge is to combine the mandatory surveillance at the nationwide level and the NRC characterization. And I have no current idea on how to do that, but I think this is really something we should work on. The global surveillance based on a large number of hospitals, and so should define a strategy to select a methodologically accepted subset of isolates that should be then characterized by a molecular method, if possible, within I mean, not prospectively, I would say, but at least within the next 6 months after the collection or after the data have been registered, because otherwise it's a bit late, so that we can trace and detect novel circulating clone with novel resistance, and be more more reactive to the evolution of the epidemiology. That's my thinking.
Yes, I agree. And then we should come up with a system that includes more than bloodstream infection, and it should be unbiased, so non-selected.
Yeah.
So then we should define what we should have in a collection on data and strains, and for strains something unselected, like every 1 in 10 strains. So that asks for a lot of collaboration with all the labs. So I'm very curious to know whether countries see this as a possibility or a no-go.
By the way, Guido, I have a question. When you mentioned that some strain were characterized by the NRC, about 3,000, how is this collection? What is the link of this subset with the cases referred to your institute? Is there any connection between the two, or is it just separated collection, just as we do in France, actually?
Yeah, thanks, Francois, for asking. That's exactly the point. I mean, we have a mandatory surveillance of bloodstream isolates, but only data are collected. And our interest is to bring these two pillars together, that, for instance, we at the National Reference Center receive those strains and do strain typing to have a much better resolution about strain dynamics, resistance dynamics, and so on. But it all comes along with numbers. When we started MRSA counting from bloodstream infections, we had more than 4,000 cases. So now we are down to 1,500, and 1,500 is quite manageable to be strain typed over the year, next to our other duties of a National Reference Center. But if I hear now that we would like to increase the number of MRSA to be analyzed not only from bloodstream infections, I see some problems for a country like Germany, having 80 million inhabitants and having higher numbers of MRSA all over the country than, for instance, in Denmark or in the Netherlands, that we reach numbers that are not anymore manageable for any kind of laboratory to be typed per year, which is then several thousand isolates of MRSA to be typed by NGS. This is quite costly. I do not see who should pay for that at the moment. But so to come to that point, I mean, there are some good reasons to concentrate on bloodstream isolates. But if we have the chance to increase the number to MRSA from other clinical cases, why not? This is a good idea, but it all comes then down to the limitations we have discussed: financial, personal, time limits, and so on.
Well, we have one other question from the audience about surveillance in livestock, in animals. Dr. Madek asks, notes that MRSA in animals has been cited in several of our presentations today. This is one of the most important crises in Europe in AMR, has been the contribution from animals. And so the general question is to our speakers today, does anyone have any plans for standardized routine surveillance for MRSA in livestock or other animals? Dr. Schouls, I think you may have had your hand up first.
Actually, in our institute, there's a department that's working on zoonotic diseases, and they have a system, and we collaborate with this department on doing surveillance in the animal reservoir. That's in collaboration with, let's say, the National Institute for Animal Studies in the Netherlands. And we are comparing isolates collected from poultry, from cattle, and from pigs. And we compare the isolates with human isolates. And in this way, we want to check whether the reservoir, the so-called reservoir for livestock MRSA in the animals, is actually seeping through to the humans. And there's another question that is related to that, is that the idea is that all livestock MRSA comes from animals, so that the animals will be the only reservoir for humans to actually contract the livestock-associated MRSA. But we have strong indications that there's quite a bit of transmission between humans with livestock-associated MRSA, particularly with the currently PVL-positive livestock-associated MRSA in the Netherlands, that is.
Dr. Larsen, your hand is raised as well.
Well, just comment on the surveillance in animals. And we have now set up a system where we receive representative isolates of from or samples from both pigs and cattle, horses, and poultry. So we have a system now for MRSA, and are trying to expand it also to accommodate that will be veterinary pathogens, but some of them could also be of interest due to a potential zoonotic spread. So that would be investigated.
Werner, you also wanted to contribute to this question?
Yes, thank you. I mean, we had a number of larger research consortia dealing with the issue of livestock MRSA. Some of them are still in charge and do some investigations, mainly on interventions. But as a result of all of these research studies, came out that there is a huge reservoir of livestock MRSA in food animals. And people, I mean, most of you already know, people having permanent contacts with these livestock animals are mostly positive. But what we don't see in Germany, according to a number of surveillance schemes, also infection-based surveillance schemes hosted by the Charité clinics, I have not talked about those surveillance schemes, is that the number of cases, I mean, clinical cases of infections with livestock MRSA is quite stable in Germany, and it's not increasing, not even in areas where we have a large livestock density. It is a kind of surprise also to us, since our daily business as a national reference center is, for instance, outbreak investigations by strain typing. And we are not aware of any outbreak with livestock MRSA in a German hospital. I mean, as I said, the strains we receive come to us on a voluntary basis. I cannot tell that there is no outbreak with livestock MRSA, but at least we are not aware of any outbreak with livestock MRSA in a German hospital so far. And this is some kind of surprising, despite the huge pressure of livestock MRSA in all the food animals, especially in the northwestern parts of Germany. I don't know, Harald, if you know any situation at a German clinic. We are not aware of an outbreak with livestock MRSA. I don't know.
No, I'm not aware of any.
Yeah.
Isn't there a reason based on the fact that those strains are not adapted to human because they don't have the immune evasion cluster?
This is not clear. I mean, since there are no cases, we cannot investigate them. But what is clear by MRSA surveillance of people with risk factors, and one of the risk factors which is accepted in Germany is contact to livestock animals. So all those people are screened by entering the hospitals. And we know that livestock MRSA coming along with those people enter the hospitals. But so far what we don't see is that they obviously not spread.
There is another question for a long time already from Henrik West from Denmark that is not on the chat. Can you give him the right to speak?
Okay, my question was in fact to I think also a comment to Guido. So given the thousands of coronavirus sequences that are being performed right now, I think the governments have identified whole genome sequencing as being a valuable add-on. So I think that maybe the future it will be more available for other microorganisms to do whole genome sequencing because they have seen that. And I would suggest that ECMID or other organizations with more power than us try to move this forward in using their contacts.
Yes, can I elaborate on that? Because I fully agree with you, Henrik, that we are now in a position that we have to know more from several microorganisms, and we started now this year with the SARS-CoV-2. For MRSA, I really want to plead for a new definition, what to collect, because only when we have defined collection, which is unbiased, because now all collections are biased because they are asking for typing, for infection control, or there is an outbreak or whatever. So all collections are biased now. So if you want to study this in your own country or internationally, you have to do it with the collection as it is. And as long as the collection is not defined on beforehand, so including livestock, including this, including that, including bloodstream infection, of course, but also colonization strains, and of course, Guido, this is costly, so we have to define with each other what is feasible. When we can define this all together and come up with a collection definition and come up with a diversity of all kinds of strains from hospitals, but also from livestock maybe, then we can study and see clones come and resistance come and go, virulence, etc. Because now we think the numbers are going down in most countries. But before it comes up again, we have to be prepared for that by having good collections. So.
Great. So we have another question from the Q&A on another, taking the conversation in another direction. It's from Runa Gokale from the US CDC. Her question is, could the panelists please comment on the benefits of the inclusion of non-BSI surveillance versus bloodstream infection surveillance alone, and how this might factor into efforts to standardize surveillance. So it seems like bloodstream infection surveillance, of course, is the most common type of surveillance we heard about today. So how would inclusion of non-bloodstream infection surveillance factor into efforts to standardize surveillance? Does anyone have any comments on that? Dr. Larsen?
Well, I think one of the advantages could be that we know that most infections caused by Staph aureus are actually skin and soft tissue infections, and they may be exposed to other antibiotics, the bloodstream infections, and thereby will also have a different antibiograms for these type of infections that we will have an interest in order to be able to treat them in the most appropriate way.
Thank you. Go ahead.
I fully agree with this remark. If you think about CA-MRSA in the last, at the end of the last century, they emerged from skin and soft tissue infection, and they were detected from patients with abscesses and furuncles, and not from BSI. So this is, I think, a really good reason to include primary skin and soft tissue infection, that because it also reflects what's happened in the community. When you look at this primary skin and soft tissue infection, it means it's not super infection. So yeah, I think this is a good reason to not only consider SAB, bloodstream infection with staph.
Yeah, and also we know that 90% of all infections are endogenous. So it starts with the nose and the throat and your skin carriers. So when you want to be before, then you should also know something about the colonization strains, because that's our future.
Are there comments from other panelists on that subject?
There was one question from the audience by Dr. Maureen Okwu. Is there a specific way of collecting samples from animals for detection of MRSA? Does anybody have an answer to this question? I've never collected specimens from animals myself.
Dr. Larsen?
Well, we use different specimen collections for different animals. They can both be individually sampled, or you can have groups of animals that are sampled. And one way of collecting these groups of samples could be, for example, if it's in poultry, we use what is called sock samples, where you simply walk through the stable with a kind of extra pair of socks on your shoes, which are then placed in Miller-Henson broth afterwards. And you can isolate MRSA from there based on a sample at the whole stable or part of the stable.
So you're not sampling animals individually, so like
yes,
pigs, for example.
Yes, we're doing that as well. If it's from horses or pigs, that is also used where it's individual samples. They can then be combined in larger batches. So you combine maybe samples from 5 animals in one tube if you're mostly interested in finding out if the stable in itself is positive rather than the individual animals, which you will often be interested in to have a farm prevalence more than the individual prevalence on farms.
Thank you. We have a question from Jesper Larsen in Denmark. Can you unmute him, please?
Hi there. It's actually more some comments about the LA-MRSA. So I just want to add some information that Anders already gave. So we do see linezolid resistance in LA-MRSA, but it's actually only in patients under treatment. So we have sequenced hundreds of MRSA from pigs, mink, and so on. And we never see linezolid resistance in those isolates, only in isolates from patients that are already under treatment. And then regarding, somebody mentioned PVL in MRSA CC398. And they are actually a human clone that is endemic in Southeast Asia. And we see a lot of cases coming into Denmark after traveling to those areas. And they are actually causing hospital outbreaks again also. And the last thing is, somebody mentioned the IEC element, the immune evasion cluster, that is generally lacking in LA-MRSA, but they can actually reacquire them. And they do that, and they do that quite frequently. And when they do that, they have an increased capacity for spreading into the community and even into the hospitals. But despite that, we have also seen very few hospital outbreaks. And now I define an outbreak with 2 or more patients. So they are very small when we see them. But they do seem to be able to readapt to humans. But there are no indications that they have actually established themselves in the human population. They still need to, originate all the time from the pig spread, but then they die out, but then they come again. There's a new wave coming. That was my comments.
Thank you very much. Dr. Schouls, do you have a response?
Yes, as far as CFR is concerned, in livestock-associated MRSA, we have 2 samples from pig farms from livestock-associated MRSA that are CFR positive. So we do find CFR in animals. Most of the pigs in the Netherlands are actually carrying livestock-associated MRSA. This is a very huge reservoir. The other thing is that we do see outbreaks of livestock-associated MRSA. We also saw an outbreak, for instance, in a long-term care facility where, if I remember correctly, I think there are about 11 persons involved in that. So it does occur, but it is indeed rare.
There is an issue raised by Jean-Yves Madec. He raised the issue of MRSA in companion animals. Is anybody aware if there is any surveillance system of companion animals? Probably the Dutch should know.
I know that the people in the University of Utrecht are looking at companion animals, but I don't think there's a structured surveillance for that. But it actually occurs, and we know from several cases where the human host actually donated its MRSA to a cat or a dog. So the same type is popping up from the animal, or the animal is contaminated by the human reservoir.
Yes, I know only from one outbreak in cats. It was about 10 cats being operated by the vet. Maybe Valerie knows more about that. So I think it's incidentally.
All right. Well, oh, sorry, Valerie, go ahead.
Yeah, I have to say, like Leo said, there's only research done on MRSA in companion animals in the Netherlands, as far as I know, and no structured surveillance. So that's only in livestock, livestock MRSA in livestock. Yeah.
All right. Well, we're a little over time. Dr. Seifer, do you see other questions?
No, I haven't.
Okay, and neither do I. So maybe we can turn it over to Dr. Vos for some concluding remarks. I appreciate everyone's patience, and I'm glad that you could stay with us a little late. I think this discussion was very useful to raise important issues about what exactly we survey in our surveillance. And we had a good discussion about livestock, companion animals, and also non-invasive infections with MRSA. And so I hope all of these topics will spark interest in this subject, and we can continue our conversation about this. So Dr. Vos?
Yes, thank you very much. Very shortly, of course, because we are over time. It was very fascinating to hear about all the differences, but also the similarities and the diversity of each surveillance system. We heard it now. So what are we going to do now? We are preparing a manuscript to have an overview of all these data from surveillance systems, and also to come towards harmonization. So we will share with you some ideas about that, and also about the feasibility. We will go through a more harmonized in the way that's not only infecting isolates or isolates without data, or data without isolates. So I think we must come up with shared, well, to say shared surveillance data, so we can share these data together, and to know and learn more from each other, and to be before seeing coming resistance, for instance, very early, to be prepared for that. So this is our main goal. As I said in the beginning, this is webinar number 1. So that means that there will be a number 2. We will think about that. First, we will prepare our data, and I hope we can reach you again in the near future to come again with a discussion like this on MRSA surveillance. I want to thank you very much for your time, for your presentations, for filling in the survey. And again, as Valerie already said, I invite you, when you will become involved in this survey, please email us or one of the panelists, and we will come into contact with you. Thank you very much, and maybe see you back live or in a webinar.
All right. Have a good day. Bye-bye, everybody.
Bye-bye.
Bye-bye.
Thank you. Bye.